Doing great.
Perfect, perfect.
Yeah, and Mallory is in Auckland, New Zealand.
Wow,
What?
She is
that's
coaching.
far away.
Yeah, she is coaching rowing at girls' school down there
Come on.
for a year. Yeah.
Yes.
Rowing.
Yep. Yep. So she thought she had been done with rowing when she graduated college, and then she got a phone call or a message from this coach in New Zealand said, "Would you like to come and be a part-time coach and see New Zealand?" So that's what she's doing for a year.
All right. Rowing.
Hmm.
What did she used to row? Sculling or rowing?
She was the varsity coxswain for the University of Western Ontario for women's team for 4 years.
All right.
So she was, yeah, she at her size, there's not much point in actually being a rower, but she was a great cox.
All right.
Hmm.
Good. So I would say, Doug, I think we could start because Nikolai just wrote that he will join in 5 or 10 minutes. So we'll start with Vasily's cave, and then if Nikolai is there, we'll do it his case, and otherwise I'll present before him. Good.
Okay.
Thank you.
No problem. All right. Well, okay. Good morning, everybody. Sorry, there's been some confusion on time because those of us who live in Europe and North America change our clocks every 6 months just to mess things up. But we're going to get started now. Our first case is going to be presented by Vasilis Likometros from Greece. Go ahead, Vasilis.
All right. I will share my screen. Hello to everybody. And this is a case from Morocco, from Mr. Hamoud, assistant professor at the University Hospital of Fes. And it's a 7-year-old boy with a dorsal skin mass evolving since birth and progressively increasing in size. It is palpable at the level of D8, D9 thoracic area. And during examination, it's a painless mass, mobile, vascularized as you can see, with a positive transillumination fluorescence, and there is no neurological deficit. There was an MRI done, and you can see this area at T1, and T1 weighted sequences with contrast. And here, I will try to show you a little bit better. You can see the mass better out of the skin and the spinal cord. This is what was sent to us by Mr. Hamoud, and we can have a discussion. This is the last slide with discussion about the diagnostic hypothesis.
Do you want to go ahead, Paulo? And
okay, thank you. So, as I put in the chat, I think we acknowledge everything, every comment that we can have on the cases that we are presenting, either your questions, your suggestions, or whatsoever. So here I see I see what looks like congenital malformation coming with a cyst-like lesion coming out of the spinal canal, probably starting intradural and then with an extradural extension. It looks like there is some kind of tethering of the spinal cord here, so the relation of the cyst, of the intradural cyst to the spinal cord is not quite clear. However, there is no contrast enhancement, so it's unlikely that this is like a tumor, or I would think more about a benign congenitally related situations such as like dermoid cyst or meningocele or something like that.
I would like to comment that usually these congenital abnormalities are separated in two kinds: the open dystrophism and the occult dystrophism, which are presented later in life. This is definitely an open dystrophism kind of mass, and there is definitely no dura mater outside of the skin, so it's going towards the area of meningocele. Mm-hmm. and not myelomeningocele.
Yeah, I would agree. Yeah, I would agree with that, because it doesn't look like there is neural tissue inside the pouch, right?
Yes. Now, if there aren't any other comments about the diagnosis, any suggestions about the management of this mass?
Don't ask me. I don't do this stuff.
That's me too. So we are both orthopedic. We need to say that we are both orthopedic, me and Doug.
Yeah.
Yeah, you are just supposed to ask. Doug,
I asked.
Yeah. Well, usually, yeah, it's of course, like Vasilis was saying, it depends on if it's causing neurology or not, and if it's open or it's closed. So this is causing no neurology, but definitely there is an open dystrophism. So it's not, I would say it's not an urgent surgery, but definitely this boy needs a correction to treat this condition, and hopefully to prevent some future complications that can arise from tethering of the spinal cord, as I was saying before.
So how would you do that?
Yeah, I think we need just a posterior opening and dissection around this kind of cyst, of this kind of pouch, and basically a plasty, duroplasty around the opening, the neck, let's say the neck of the dystrophism. If there is some, I always look inside the dura to see if there are adhesions or tethering. If there is, I try to relieve this, but the most important then is just to close, to do a dural suture. Just presuming that this is a dystrophism, that I believe it's the most likely. I think a different thing, like I was telling, like a dermoid cyst or epidermoid cyst, doesn't look like. So this definitely looks like, yeah.
And those you'd expect enhancement, I would think.
The
dermoid cysts. You'd expect it's an enhancement.
Yeah.
Mm-hmm.
So Nikolai is there already.
Nikolai and Salman Sharif, they could add comments on management of this meningocele.
I agree with Paolo. I think what he said is good.
You're a man of few words this morning. Or actually this evening, I guess, for you.
I missed the comment. Sorry, I don't know what it was suggested.
Yeah.
Just a dorsal primary closure.
Okay, I think this is a good option.
All right.
Okay, well, it seems like we've beaten that one, and there aren't any questions coming from the chat line. So why don't we move on now to the second case? And the second case is going to be presented by Nikolai Payev from Belfast. Nikolai.
All right. So do I share the case, or it will be shared by?
No, you share your screen, because that way you can manipulate it.
Okay. So let me just open the case then. In a second. Apologies for my late jumping. It was some confusion with 1 hour. I was thinking that is 1 hour from now, and it's definitely okay, just launching the Dr. Faisal Putra from Bandung, Indonesia. Do you see my screen? I guess no.
Not yet. We're still seeing you.
Okay, let me see if I can share. Right. So for some reason, I cannot share the screen. So, Imad, can this be shared by somebody else, by you? I'm having difficulties to open my.
Shall we proceed with Paolo and then come back to you?
Okay. Yeah, sounds good. I'll try to make it work.
Oh, hang on. Okay. All right. Here, Paolo's got your case up. He shared your screen, his screen with the case. So.
Oh, so this is the case that I have to present. This is the case now.
Yeah.
Okay.
Yeah.
Right. Okay. So as I said, this is a case that is coming from Indonesia, from Bandung, from Dr. Putra. So next, please. It's a pediatric case, 7-year-old male that presented with a lump on the back for many years. And for the last month prior to presentation, weakness, upper limbs and lower limbs. Also bowel and bladder problems, also pain, and there is nothing else so far from the past medical history. Next. You can see quite significant upper limb weakness, 2 out of 5, and the lower limbs is 5 out of 5 throughout. Next, please. And this is the scan. This is the scan that is presented to us. So obviously it's a ginormous tumor that is engaging the nearly the whole posterior aspect of the cervical region. It's a bit, the images are a bit tiny for me to see details, but by the looks of it, I do see that there is a cord swelling there, which is I'm difficult to assess more than that and to be a bit more assertive of what I see there because the images are a bit small.
As an aside, just as an aside, to people who are presenting or who are submitting cases in the future, please just pick selected images and blow them up so that we can actually see. It's very difficult when you have 9 or 10 images on a slide to focus on them.
I completely agree, and I join with that appeal. Yeah.
Paolo, can you try blowing up the sagittal T2? Yeah, there it is. Okay, that gives us a little better view.
Yeah.
Thank you, Paolo.
Okay.
All right. Go ahead,
So
Nikolai.
obviously, cord compression at that level is explaining the upper and lower extremity weakness. By the looks of it, not entirely sure, but by the looks of it, we are talking about a tumor that is starting inside the canal and is going out through one of the foramens. I think it's C2, C3, if I'm correct. And it's we have a tumor that is probably neural sheath tumor from what I see here, because I'm continuing to with a possible diagnosis, because this was the question that the author is asking: what is the possible diagnosis, and what are we gonna do, and how many surgeries we're gonna have for this kit. So definitely the first stage will be urgent decompression of the spinal cord, and then I probably will team up with maybe with an ENT surgeon to see how much of that I can remove, especially that part that is laterally and going forward. So I think that would be my approach. I'm not sure if I will be possible to remove that tumor as one go. It might be possible, depending on, obviously I have to look into the images a little bit more carefully to give you exact strategy. Definitely it's a large tumor that you may consider staging it in case one stage is not enough. If I'm not possible to take it out, definitely my first goal will be to get to the cord and to decompress the cord as soon as possible, and then I have to focus on what else I can do later on. I don't know if I will be possible to do that in one surgery, or I will be possible to do that on at least 2 stages.
So we had a question from the participants. What about establishing diagnosis first? Would you consider biopsying this first?
That definitely is something that we can consider. However, having in mind that the kid is also already with weakness, I would probably try to decompress the cord as soon as possible, because obviously histological diagnosis might take some time, and I would like to decompress that cord as soon as possible.
Does it make a difference that he's been weak for about a week?
Well, I still would consider decompress. Yeah, well, definitely it's not acute, but it is not. It is 1 week is a long period of time, but still, in the pediatric population, I think I would try to decompress that as soon as possible, and then the histological diagnosis will be byproduct of what I'm gonna do on first stage or the surgery itself. You can also consider sending intraoperative sample to your pathologist to tell you what are you doing, because you're gonna be there for a while with that tumor. So I think that I would definitely go and decompress the tumor as soon as possible.
So what approach would you use?
I will start with midline posterior approach.
Okay.
And I have to remove lamina of C2 and possibly C3. This is
Well, you'd have to do something about that. You'd have to do something about that mass first, wouldn't you?
Yes, well, obviously I have to go through the mass. That mass will be taken as much as possible. With the first bites from that mass, I will send a sample to my pathologist to get me oriented. What about the histopathology? And then obviously that may swear me to one or another direction.
Okay. Paolo, your thoughts?
Later on, you know, if you have to do decompression of C2, C3, if you remove the masses there, obviously this is a small kit that might have consequences later on in terms of stability of the neck, but that will be addressed on a later stage.
Paolo, your thoughts?
Yeah, I think, well, this is definitely a very big thing, a very huge tumor. Stacy was commenting, I always try to biopsy before and know my enemy. That's my approach for all the tumors, unless there is a urgency of the decompression as Nikolai was saying. So apparently the neurological deficit has been progressing for 1 month, so that could urge me to do something quicker and not to wait like 10 days or so for a pathology result. But otherwise, I definitely would like to know what kind of tumor this is. Regarding diagnosis, I think this is very, very atypical for a nerve sheath tumor. I think because of the age, because of the multilocular appearance, particularly going even towards the contralateral, all these kind of extradural and in the extension in the posterior neck, I think it's very atypical for a nerve sheath tumor. I would think more about something like a bone tumor, such as osteoblastoma, Ewing sarcoma, or something like that, which are common in this age. Some other kind of soft tissue sarcoma could be an option as well. I think this is too big. I think this. I understand this is coming from Indonesia, and I know some infection can mimic tumors, but it definitely doesn't look like an infection, at least for my eyes. Yeah, I don't know. Maybe a teratoma could be another possibility. I think this is basically extradural. Even the intraspinal component, which we could see in the axial cut, looks like to be extradural. But then there is a big extension, either to the posterior neck, to the lateral, to the posterior pharynx. So this is definitely a very big tumor. So my first hypothesis will be something malignant, I would say.
I would like to make also a comment. There are some questions about fixation, and fixation goes with instability. We definitely, in our diagnostic tests, we should include CT scan in order to properly see the bony tissue and evaluate if there is a full destruction of the bone of the cervical vertebra, especially T2, C2 and C1. And then we will evaluate if there is an immediate need for fixation after the first at least approach, or there is some stability that we can take advantage later on.
Yeah, no, I agree. I think a CT here would be very helpful. Also, it would help with, as Paolo was saying, to look at whether this is a primary or not. Because if the CT, so we do have CT here.
Now, I want to make a difficult question. If we see from the CT that it's probably, or maybe from the biopsy also, if it's a Ewing sarcoma, and it's so huge and so contaminated, what is the future?
Yeah,
even after 2 or 3 stages.
Yes, that's again part of the reason why I think that given that this young man has been weak for a month, I think this is one where I think the idea of getting a biopsy first, but it is probably still going to be good, because if this is something like a Ewing's or something like that, it's going to alter how you're going to do this. I mean, obviously, there's no potential here if this is a Ewing of the curative resection. But if it's a Ewing's or something like that, you may be able to do a less destructive surgery with neoadjuvant chemo and rads.
Yes.
Agree with that. That's why, as I said before, I always try to get the diagnosis before, unless there is like a surgical emergency to decompress the spinal cord. Yeah, and definitely if it's something like a Ewing family tumor, the oncologist can give a good help on kind of addressing it from a complementary treatment for the tumor.
There have been a number of questions about the length of, if we're going to stabilize the length of construct, and I think that's it's very different in a 5 or 7 year old than it would be in a 50 or 60-year-old, how you would do it, because of the inherent healing ability of kids and the concern about stopping growth and things like that. So in general, in pediatrics, we would try to keep the construct as short as possible.
Yeah, I think I even would try not to fix primarily if possible, depending on how much I have to destroy. We were seeing the CT scan, but to be honest, I could not see exactly what is destroyed on this CT, because it's just like a sagittal and coronal, so I don't know how much bony destruction there is. But but even just thinking about decompression and keeping it like that and see how it evolves, how it relates, how it behaves after chemo or radiotherapy, and try to postpone, if possible, a fixation that could be a long one. I will try to play with that.
Another question that came up is, would you consider involving plastics in terms of closing this?
Yeah, this can be an issue because the tumor is basically occupying all the posterior and left lateral neck. So we almost see no muscles there. So
I always figure in these big cases, the more help you have, the better off you're going to be. And I mean, obviously, I don't do pediatrics and I don't do this type of tumor, but if I were doing something like this, I would be very happy to have my plastic surgeon around to help me.
So I ask you a question. What would be an emergency? The statement was, if it's only go straight, only if it's an emergency. What would be emergency? The kit is 2 out of 5 and 3 out of 5, and although it's been progressing for a while, the way I got it is that there is a rapid progression over a short period of time. So would that not be an emergency for you?
So there's a difference between a progression in the last 12 hours and the last 12 days.
Okay.
I think that,
you will not
since
be,
the
you will not
progression,
be prompted by that 2 out of 5. Yes.
it would still, again, if it's I think that the benefit of knowing what it is, again, if this person had presented 1 out of 5 that's deteriorated over the last 12 hours, I don't think you have much of a choice. I think you have to go ahead and decompress the cord. In something where it's progressed over a week, I don't think an extra 2 days to get your biopsy result is going to make that much difference in terms of the neurologic recovery potential. And it may make a huge difference in terms of your plan.
Yeah.
Obviously,
I agree with that. Yeah, but
always
again,
good to have more information. Yeah.
Yeah, we don't know exactly how far this. Well, we know this is progressing for a week or so, but I don't. We really don't know if it's stable during the last 2 or 3 days, or if it's really worsening during the last 24 hours. That can make a difference, definitely. And of course, if you have to go there, as you were saying, if you see this boy progressing and worsening every hour, definitely you have to go there and do what you can just to take out what's around the spinal cord and take out what you can from the neck, because this is also in your approach. So you have to go through the tumor to reach the spinal cord and the spinal
What
canal.
about, Paolo, what about if you had to do this in an emergency? What about doing like a left-sided white sides approach, opposed to coming from laterally? Because that way you could avoid going into the bulk of the tumor, get the cord decompressed, improve your neurologic status, and then give yourself a little bit of extra time to figure out a good plan rather than coming in from the back and trying to get it all out.
Yeah, you have tumor in the back, in the lateral, and in the anterior part. So it's really difficult to find a place where to go without finding any tumor. So
yeah, but I'm just looking at the one of the axials here, and it looks as though, I mean, yes, you're still going to have to go through a bunch of tumor, but it looks like if you were to do a white sides approach, you could come through. You're looking at, instead of going through 12 centimeters of tumor, you look like you're going through about 4 centimeters of tumor.
I think you have to be very, very careful, confident with white side approach, because the anatomy will be already distorted. And at least in my hands, I don't know about you guys, but that approach is not everyday approach.
Yeah, same for me. So if I have to go there, I'll do posterior midline and try to take out what is there and what I can take out, and then do a laminectomy and decompress the spinal cord. That's what I would do if I need to go. Yeah.
Would you try and essentially try and get I hesitate to use the word en bloc, but at least that posterior mass, you'd try and take it out as one blob rather than going piecemeal through it?
I would say it's very difficult to take 8 or 9 centimeters mass, like en bloc, even en bloc like. I would try to go around and take as much as possible, but and also it doesn't look like a ball. It looks like a kind of very irregular kind of mass with septa. I don't know.
Okay.
I don't know if we have any more input from the presenter of the case. I don't know if this is like a solved case or not. I don't know if Ruli has some more information about the case that could share with us. I don't know.
I would like to make a comment about what Doug said before, that in pediatric population, we try to make the fixation as short as possible. In order for the lower cervical spine to have better stabilization and short and fewer vertebrae, we can add pedicle screws instead of lateral mass, which are very stable, of course, are very difficult to do. But for example, in this axial section that we see there, we can have the right pedicle ready for a screw with great stability there.
Yeah, I think to look at fixation, I would have to even think about looking at fixation. I'd need to have a much better look at the CT.
Yes, of course.
Okay. All right. Well, this is an interesting discussion, but I think we need to move on because we just don't have enough information to complete this. Thank you, Nikolai, for presenting this one. We're going to move on to our last case now. This is a case from Ireland, from Stacey in Dublin, and this one is going to be discussed by Paolo.
Okay, so let me try to put this in full screen. Okay, I think this is now. So first, thank you, Stacey, for joining and for sending this case. So 78-year-old Syrian retired orthopedic consultant who is now a resident. So you have like very old residents in Ireland, I would say. So ankylosing spondylitis, spasmodic angina, stable, medically optimized, no horizontal gaze, loss of independence when outside, neurological intact, and the DEXA score is -4, and osteoporosis has been treated for 1 year, and again, angina seems to be stable. This is a kind of a nightmare for me, but I wonder that should be like a kind of nightmare for anyone. So we have this big deformity coming from a complete loss of sagittal balance coming from the ankylosing spondylitis. We see also the bone loss coming from related to the osteoporosis and some fractures at least L4 and probably like T1 or so, 2, 3, 4, 5, 6, 7, T2, and we have basically a big angulation in the cervical thoracic area, and we have all the rest of the spine is kyphotic. So
one other thing to note, because it can be important, is note that he's also had a sternal fracture.
Yeah. Oh.
And you can see he's buckled his sternum there. That makes correction somewhat more difficult.
Yeah. Oh, that's nice. I hadn't seen that.
Yeah.
Okay.
I have.
Okay. And so questions are from Stacey: are surgery or not? Not is always easy to answer. So.
And just as an aside for the participants, Stacey has just posted that we don't have an MRI because he won't fit in the scanner, so don't ask.
Okay. That's also an easy answer. And so it's basically, should we operate on this colleague or not? And if we are going to operate on him, what to do?
And then also questions about how to position and minimizing risks.
Yeah.
Well, since this is kind of what I do, I'll jump first.
Okay.
In general, your goals here are A, to keep him alive and neurologically intact. So that's where you need to look at how 78 is he. like what his overall health status is. And one of the principles in ankylosing spondylitis surgery, although his primary complaint is probably the cervical thoracic deformity, is probably most affecting his function right now. If you feel you need to fix both the thoracolumbar and the cervical, it is vital that you do the thoracolumbar deformity first, because the risk is if you correct the cervical first, and then you go back to do the thoracolumbar, you run the risk of having him overcorrected so that he's no longer able to see near space, that his chin brow vertical angle becomes positive rather than negative. And so that's a very important thing. Stacy has just put in that he's not on any DMARDs, disease modifying agents, for ankylosing spondylitis, which at this point, there's not much. Once they're at this state, in ankylosing spondylitis, the disease modifying agents, the role of the DMARDs is to prevent this from happening, to prevent this pan fusion, and also to protect the large joints, the hips and knees. And Stacy has already said that the hips move well, and that's important to know. So I would probably start with the thoracolumbar spine, and I would look at doing a pedicle subtraction osteotomy. Probably just because you can get more correction through it, I would probably do it through 3 here because it's a taller vertebra. I don't think I would do it through 4 because you've already lost some anterior height. In terms of positioning, what I find works really well for the ankylosing spondylitis patients is I put them all in Mayfield pins. But what I do is I do this on a Wilson frame. And essentially what you do is when they're lying on the cart before surgery, you sort of look at their curve and you sort of dial up the Wilson frame to match their curve. And that way, when it comes time to close the osteotomy, you can flatten the Wilson frame during the surgery to help with the correction. I would certainly do this with neurologic monitoring. Stacy, what osteoporosis treatment was he on? Was he on an anabolic, or has he just been on anti-resorptives? Anabolics, good, yeah. Yeah, you'd want him at least, and as happened here, at least a year on an anabolic. Construct length, there is no physiologic cost. Yeah, I think it would be good to have Stacy unmuted. There's no physiologic cost to a longer construct here. So I would be putting screws everywhere I possibly could. Usually if somebody's fused across the SI joint spontaneously, I don't put iliac fixation in. But again, here with the bone quality as bad as it is, I probably would do iliac fixation. And then I'd want a 4-bar construct across the osteotomy site.
You and I think very alike.
Sorry?
You and I think very alike.
Yeah, yes. Yeah. So and then in terms of then addressing the cervical thoracic junction, the timing of that would be based purely on how he did after the thoracolumbar. If he sails through it, then I would look at about the 3-month mark. Give him time to recover. If he had a rocky course, I'd probably look at more like 6 months before I want to do the second stage. The cervical thoracic, it's interesting, you look at the original descriptions by Ed Simmons, the cervical thoracic deformity, he classically would do that at C7. And it's interesting, if you talk to the people who do a lot of this, everybody's moving further and further
lower down
bodily with it. I now for these do a T2 osteotomy. For a couple of reasons. One is that, so if I look back to C7, the problem, your first fixation point, if you're using C7, is a lateral mass of C6. And if you're going to use your hardware to close your osteotomy, you don't have a very good biomechanical there because the angle of a lateral mass screw. So I like having a pedicle screw there. I like having two pedicle screws. So I will put a C7 pedicle screw, a T1 pedicle screw, lateral mass fixation everywhere. And the one key in ankylosing spondylitis that people forget is that the ribs are also fused. So if you're going to do a T2 osteotomy, you have to do a resection of the proximal portion of the T2 rib, and you have to do a resection of the T1 rib. If you don't do the T1, if you don't take the T1 rib head as well, you won't be able to close the osteotomy. So you have to take both rib heads. And then the other advantage of going down to the advantages of going down to T2, better fixation, but also better, lower risk of loss of hand function. A T1 osteotomy puts the C8 nerve root at risk and the T1 nerve root at risk. T2 osteotomy, the T1 nerve root's a little bit at risk, but you, for instance, you can take the T2 nerve root to get a better osteotomy. So is T1 the fractured level, or is that T2?
It's
T2.
T2.
Yeah, that's
so
unfortunate.
So this is
that's unfortunate, but
the osteotomy at the level of the fracture, right?
Yeah, I would do the osteotomy at the level of the fracture here, because if you look, he's actually got good cervical lordosis. And I think and I think, again, the worry that I have in these, I've always worried, and how much correction I'm going to try and get is going to partly be based on what his chin brow vertical angle is after my thoracolumbar correction, because the absolute worst thing you can do to these people is overcorrect them. You're better off undercorrecting than overcorrecting.
So I did his L4 PSO 4.5 weeks ago. Which you can see there. I went for iliac fixation. And did obviously big pedicle screws, went up to T11, just from the point of view. We got a decent enough correction with them. And we went from being slightly kyphotic to straight to verging on lordosis. He sailed through it. He was in ICU for 24 hours, extubated the following morning, went to ICU 7 o'clock in the evening, extubated the following morning, back up on the ward the following evening, sailed through it.
Nice.
So he's doing very, very well. He also has 2 medics in the family as well, just for good measure, because if you're going to operate on somebody who's high risk, make sure there's at least 3 or 4 medics in the family, because it's fun.
And those are good conversations.
They're great conversations. So yes, my plan, he's sailing through it. He's currently contemplating stage 2. My feeling is, because he sailed so well through it, we will probably be aiming for at the 6-week mark. So a week on Tuesday is looking like D-Day if he wants to go with it early. Otherwise, I will see him back in the new year with a view to planning him between 3 and 6 months if he wants to go ahead. Pain's a bit of an issue for him. Because he's very limited in what he can tolerate analgesic wise. So that's his biggest problem, is pain. But I say he's up and around, completely independent. He's one of
the things that, you can't do it obviously for the cervical thoracic junction, but one of the things that I do in all of my big cases like this, I actually put an indwelling epidural catheter in for the first 3 days. Because that way we can manage it with a lot less narcotic, particularly in the older patients.
Yeah, he's just struggled a bit now with trying to be more mobile. So I went for the L4 PSO just to try and get a bit more correction from him, and also just the risk from a neurological. But I did I kind of used the disc space of 3-4 and took that all out.
You did a Schwab 4.
Yeah.
Nice. So basically,
L4 PSO.
That was the level of the fracture, right, Stacey?
I took the 4 fracture level.
It was the lesser of the 2 fractures, at least.
Other thing I did with him preoperatively is, at the end of one of the lists prior to, I brought him in a couple of days early. I brought him down to theatre fully awake and positioned him on the table to see how he'd tolerate it, fully awake. So he hopped up on the table. So I actually did him on a 4-poster frame. Wilson didn't work for him. I mean, his head was pointing towards his feet right enough. It was good fun. The anaesthetist was freaking out. My biggest concern was obviously visual loss and also cerebral edema. So we were very careful with our monitoring for that, and obviously had to be super efficient whenever we had him prone, just from the risk of his head injury risk an eye injury,
Yeah.
but absolutely, thankfully, absolutely spot on and neurologically fine with his monitoring throughout. So
Nice. Vasilis, do you have any thoughts on this one?
I wanted to ask about your experience of doing the osteotomy on the fractured level. Usually the bone is harder and it's difficult to do the subtraction. And what was the gain? How many degrees did you manage to have lordosis?
So we've gone from being quite kyphotic to lordotic. When you measure it out, I think we improved him by about 25 to 28 degrees, depending on what you measure from. So
And again, I'm going to make to the audience, with the ankylosing spondylitis patients, your goals are different than, and the risk is always overcorrection. So, just remember that.
Yeah, I was about to ask how likely do you think it is that you have a PGK there at T10 or so?
Generally not, because remember they're fused.
It's fused.
Yeah.
They're fused.
That's the good thing.
Yeah. So generally PJK is not an issue with these. More an issue is and the nice thing again, you've got somebody here who wants to fuse. So usually the healing, the bony healing is pretty good.
We got great bone-on-bone contact actually after the osteotomy, and actually during the closure of the osteotomy, the anaesthetist was very impressed by how much his ventilatory function actually improved.
Oh, that's always a bonus.
He had high intraoperative airway pressures throughout most of the case, manageable but high, but they dropped by a good 3 or 4 just by closure of the osteotomy. So the anaesthetist is much happier for phase 2 in that he knows he can ventilate him for several hours now.
Stacy, that was going to be my second question, and you had it answered. We can see here on the right image that from the pelvis until the sternum, through the osteotomy, the whole abdominal anterior wall has been extended, and that must have released the diaphragm.
So his pressure dropped quite considerably. So the anaesthetist was delighted with the osteotomy, and the patient, I say, has had no issues ventilatory post-op, which has been fantastic. I say he actually has sailed through much better than I would. So the reasons for doing the lumbar first, because we had great debate as could we tolerate doing both osteotomies in the same sitting, and I was told that was a ridiculous idea. Don't even contemplate it.
Well, and again, I would say the other reason for not doing them together is that risk of overcorrection.
But the advantage with this is like the first date. So we saw how he managed the first date. He's tolerated it very well. So he's contemplating the second date, which we'll see how he gets on.
How
do you do your cervicals? Do you do them sitting or prone? Because I'm going to navigate him for his cervical.
I do them. I still do them prone.
That's what I'm going to do. I've been playing with the tables. We've got a new flexible Allen table, one that bends or something. So I'm going to do them prone. But everyone was talking about doing them when I've been chatting before with people about sitting.
Well, that's the way Ed Simmons classically described doing these, and I find that just more of a hassle than it's worth. I did one in the sitting position as a resident and hated it, and I have not had any problems doing these in the high thoracic osteotomies in prone position. I think the Mayfield horseshoe works real well for closing the osteotomy, and I like it that way.
That's what my plan is to do in prone, one so I can navigate, because I'll do cervical pedicles in whatever I get into. I'm thinking probably T1 osteotomy is where I was thinking, but I will take into account T2 is obviously where the main deformity is. But my concern was obviously the ribs and getting the correction with the ribs.
So but you just do a really good resection of the T1 rib head. Take it about 1 centimeter from the tip of the T1 transverse process. And when you're doing it, when you get in there, the T1 transverse process and the rib are essentially one bone anyway. So you just take it good and wide, and it usually, but you absolutely have to take that T1 and the T2 rib head.
Perfect. Yeah, this always freaks everybody out when you talk to deformity surgeons, because obviously Anki-Spond is not the same. I'm not looking for absolute balance here. I'm looking to give this man a bit of quality of life and to get him back wandering around outside by himself.
Yeah, you're aiming for a chin brow vertical angle of about 10 to 15 degrees down.
So when I met this man for the first time, he sat on the chair in the clinic, and for me to make eye contact with him, I sat on the floor.
Mm-hmm. Yep, been there, done that.
So, yeah, he did present in Syria, but he was kind of told it wasn't really a high priority there. There was something like a war going on, so he wasn't going to get surgery in Syria. So
the story when Ed Simmons was started doing these, the first patient that Ed Simmons saw that he did this on was a guy who walked backwards, looking under his arm to see where he was going.
Yes.
Yeah. Okay. Well, we'll be interested to see what stage 2 looks like when you're done, Stacey.
Right. Hopefully we'll get away with 2 stages and not have to do a mid-thoracic as well. Should get it with
actually, that is one that I would do is I would actually go down because again the physiologic cost of fusion of instrumentation in this guy, I would actually go down and I would connect into the old hardware or to the previous hardware, just because if his osteoporosis was -2, I might not. But at -4 after treatment, just the stress riser of by the time you come down.
-4 is before. I haven't seen him up to date, Dexa, but yeah, his bone quality is not.
Yeah, so I would lean towards connecting them together.
Yeah, see, here we go.
So you drew basically like C4 to or C5 to the rest of the
C4 to pelvis.
Yep.
Yeah, because even the thought of the danger of having a fracture later on between the two instrumentations.
Yeah, no, there's not a physiologic cost to doing it. So you'll sleep better if you connect the two constructs. All right. Well, this has been a very good discussion, people. Thank you to the faculty for participating. Participants, thank you for being here. And Paolo, our next is December
17th.
December 17th. All right. We will see you all on December 17th. Okay.
Thank you.
Have a good day, everybody.
Bye-bye. Thank you.
Everybody.
Thank you.
Thank you for your cases.